Alirocumab and Cardiovascular Outcomes after Acute Coronary Syndrome. Definition: in the Odyssey Outcomes trial, we tested the hypothesis that treatment with alirocumab, a fully human monoclonal antibody to PCSK9, will result in a lower risk of recurrent ischemic cardiovascular events than placebo among patients who had an acute coronary syndrome within the preceding 1 to 12 months and who have levels of atherogenic lipoproteins that exceed specified thresholds, despite statin therapy at a high intensity dose or at the maximum tolerated dose.
The rationale of the Odyssey trial was really that lower levels of LDL cholesterol would reduce important cardiovascular events, potentially including mortality. The design was to test that hypothesis by randomizing patients who had an acute coronary syndrome 1 to 12 months prior to either the PCSK9 inhibitor alirocumab or to placebo, and then to follow them over hopefully several years. That was the plan. We ended up actually following them for a median of just under 3 years. And the goal was to see if there was an impact on cardiovascular events, including mortality.
Pros and cons. The median duration of follow-up was 2.8 years. A total of 334 patients in the alirocumab group and 392 patients in the placebo group died. The absolute benefit of alirocumab with respect to the composite primary endpoint was greater among patients who have had a baseline LDL cholesterol level of 100 milligrams or more per deciliter than among patients who had a lower baseline level. The incidence of adverse effects was similar in the two groups, with the exception of local injection site reactions.
So we did the Odyssey Outcomes trial to test the hypothesis that patients with recent ACS not at goal on maximal statin therapy would derive clinical benefit in terms of outcomes from adding alirocumab to their secondary prevention therapy. And we did this because despite all the progress we've made in the care of ACS patients, they remain at substantial residual risk. In fact, they are the group of all patients with acute coronary disease, with coronary artery disease, who have the highest risk of subsequent adverse events. So we tested this in a large outcomes trial, enrolling patients not at goal on truly maximal statin therapy following an ACS 1 to 12 months prior to that. It was a double-blind randomized trial. Patients received either alirocumab or placebo every 2 weeks subcutaneously in blinded fashion. Median follow-up 2.8 years, high-quality data. The results are very simple. Number one, we met our primary endpoint, which was a reduction in MACE by 15%, which is exactly what we set out to do. The next bonus finding that we did not expect was a 15% lower all-cause mortality in those patients. Now we have to be careful with the interpretation of that finding because of technicalities in the statistical analysis in which we pre-specified other events in the order of analysis. But still, all-cause mortality was lower, and that's an important finding. The third finding, which is a pleasant surprise as well, is the remarkable safety of that compound. In particular, there had been concerns regarding neurocognitive events, new onset of diabetes, cataracts, intracranial hemorrhage with these potent LDL-lowering agents. And we found that with alirocumab, given for years in these patients, over the duration of the trial, with that caveat, over the duration of the trial, there was no serious safety signal. So it's a therapy that's effective, it's remarkably safe, so the risk-benefit equation is extremely favorable, and it's associated with reduced all-cause mortality, which is really important. Now, where does this take us? Well, I think there are two questions that remain to be addressed. The first one is, can we start this therapy in the acute stage? We enroll patients a few weeks or months after an ACS, but ideally you wouldn't want to wait to start therapy because we know that if we delay starting therapy, many of these patients are never going to get them. We would like to start early on when they're still in the hospital, which is only a couple of days nowadays in the care of MI patients. The second question is, who are the best targets for this treatment? From our data, some of our analyses suggest that the best targets are the patients who start off with the highest risk and the highest baseline LDL, in whom the magnitude of the treatment effect was greater, a 24% reduction in MACE, a 29% reduction in all-cause mortality. And if we have to start somewhere in our cost-conscious environment of today, I think this is where we should start.
Applications in medical English. Patients who have had an acute coronary syndrome are at high risk for recurrent ischemic cardiovascular events. We sought to determine whether alirocumab, a human monoclonal antibody to proprotein convertase subtilisin kexin type 9 or PCSK9, will improve cardiovascular outcomes after an acute coronary syndrome in patients receiving high-intensity statin therapy.
We're a little hampered by the fact that while the Fourier trial has been presented, published, and produced a host of post hoc analyses and additional publications, the Odyssey trial has been presented, but we have not yet seen a peer-reviewed document and a published article, never mind a variety of published post hoc analyses. So I think the data is less sparse with alirocumab than evolocumab, so I think it would be very difficult to parse out indications or recommendations when you don't really have the full story from both drugs. I think the drugs work in a very similar mechanism. Cost is always a concern. I don't know what we're going to see in the next set of guidelines, but potentially at least including cost in the way we think about and understand additional or incremental medication allotment, it might be a key part of that. And so where cost lays out in the difference between these two drugs may play a role in choice down the road. But certainly as of today, that has not made its way into our current guidelines and thinking. When you look at indications for medications, I think it's often based on the way trials were designed. And so at least currently we have two trials that were designed in patients with atherosclerotic cardiovascular disease. Unfortunately, there was a trial going on with a third PCSK9 inhibitor that was looking at high-risk primary prevention patients and was not followed through to completion because of a loss of efficacy over the course of the first year that the patients were studied. The drug wasn't unsafe, it just seemed to lose its benefit due to the generation of antibodies. So the only population that's really been studied in a randomized prospective fashion is the highest risk ASCVD population. We would all love to see an expansion of the indication to what we assume to be equally important to treat high-risk primary prevention patients, the diabetic patient with hypertension or smoking, or the patient with subclinical atherosclerosis, patients with elevated lipoprotein A, etc. And so I hope as time goes forward, trials like that are designed that will allow it better inform us as to whom we can additionally use these drugs with an expected benefit.
Issue applied in Ecuador. FDA approved the use of alirocumab for commercial purposes as an option to conventional treatment for ACS or acute coronary syndrome, meaning that this drug could come to Ecuador in any moment. In conclusion, among patients who had a previous acute coronary syndrome and who were receiving high-intensity statin therapy, the risk of recurrent ischemic cardiovascular events was lower among those who received alirocumab than among those who received a placebo. Thank you very much.